Welcome to the third module of PCR webinars on left main PCI. The topic for today's session is to discuss complex bifurcation PCI in left main using two stents. And we will do this today by reviewing some cases of our daily clinical practices. My name is Gabor Toth from Graz, Austria, and it's my privilege to be here together with Cristoph Naber from Zurich and Marko Noc from Ljubljana. As mentioned, the objectives for today is first of all to understand the indications of complex left main PCI, but also to discuss stepwise how to perform two-stent strategies in left main disease. And as said, we will do this by reviewing two cases which was Marko facing with during the last couple of months. So I let you digest a bit these two angiograms, and in the meanwhile, I already asked Chris, what are the first things that come to your mind when you look at these angios?
Yeah, Gabor, I think the first thing we should have in mind is that this is an angiogram and not a patient. So I think we always need to integrate a little bit the patient and his history, the clinical issues of this patient. We need to look at the anatomy for sure, which is very important. And I also think it would be very good to think of the own experience we have.
So understanding this recommendation, I ask immediately Marko to present these cases.
So let's go with the first patient. So 82-year-old lady, clinical presentation, high-risk non-STEMI, and a little bit reduced left ventricular ejection fraction with anterolateral hypokinesia. So let's go to the angios now. This is the RAO projection of the right, dominant coronary artery, and LAO on the right side. And you can see that there's a tight lesion in the distal right, and there's also at least moderate disease in the mid portion of the RCA. What about the left side? Here you can appreciate areocranial and areocaudal position. And you can see already the problem, which is very nicely seen in the areocaudal position. So this is essentially subtotal distal Medina 1-1 lesion. The left views, I think it's always very important to get information from different views, because then you can really appreciate the whole anatomy. And as you can see on the LAO-caudal, that's not much added information in addition to the RAO-caudal. But importantly, I would emphasize LAO-cranial tells you that there's basically no osteal disease, and that the disease is mainly located to the distal left main, spreading out to the ostium, the circ, and the LAD.
So thanks for this presentation. Before you give us the solution for this case, I would like to ask Chris again, when you are facing this patient in your cath lab, what is your next step? Is it the patient to do PCI right here, right now, discuss with surgeons, send for surgery, or plan it for a second procedure?
Gabor, I think this old lady, she has a slightly reduced left ejection fraction, but the disease is relatively focal. We have mainly this distal left main lesion, not much more disease on the left, and we have this focal lesion on the right. So with this focal type of disease and the age of the patient, I would rather think of PCI. I think of faster recovery of the patient. Normally we would take this patient off the table, would try to explain to the lady the options she has, speaking about CABG, speaking about PCI, take the option maybe, because we will have PCI in mind for this lady rather, maybe also to load her with dual antiplatelet therapy, and then prepare her for the next day, maybe for PCI or 2 days later.
I completely agree that to perform PCI in such a setting without preloading, it's not necessarily the best thing to do. So Marko, how did you go on?
So basically, this lady presented as a high-risk non-STEMI. So she went straight from the emergency department to the cath lab, where we obtained these angios. And then we are fortunate in our institution that we can have this concept of acute cardiac team, which means that, when we get all this information Chris mentioned, then we can call the surgeon to the cath lab at any time while the patient is still lying on the table after coronary angiogram. And then we discuss pros and contras. There was no doubt for this patient that she needs revascularization. We were discussing, as Chris mentioned, whether we do percutaneously or surgery. And then basically we came up with the same conclusion as Cristoph emphasized. And then we went to the lady and told her that based on our discussion, we think that that would be optimal strategy, and of course ask for the consent. Basically, our decision was that we first go for the PCA of the RCA, which looked straightforward. It's a dominant RCA. We thought it would be helpful when we attack the left main, that the RCA is nicely fixed. And then, of course, the second stage within the index intervention, of course, will be go for the left main and try to solve the left main. And for this particular case, I selected intra-aortic balloon pump support up front. So before I touch even the right, I put the balloon pump. So this
is not your normal procedure, because I was wondering a little bit, intra-aortic balloon pump, I rarely use in these cases. I think going fast and very precise and not choosing extra loops and extra steps, being really prepared, I think is something which is very helpful in these patients. And I personally have more experience than using maybe ECMO and a few experience on the impeller, but rather not use intra-aortic balloon pump. What is your reasoning for using that?
So first of all, I fully agree that the strategy, PCI strategy in this patient should be very straightforward. So you always have to have plan B in case of something goes wrong, or if you cannot do it. This is the key. But for this particular patient, because of these subtotal lesions, I felt much more comfortable if I put upfront balloon pump, even though I'm very well aware that scientific evidence is scarce. I agree with you.
Okay.
Yeah, I think it's a nice approach that actually with balloon pump you don't need a very huge access site to place it, so you can actually stay on the safe side during the whole procedure. So you decided to go on first with the right, the PCI of the right. How did it went?
So the right was rather straightforward PCI. I put 2 stents and end up with good angiographic result, and I didn't use much contrast for this one. And then, of course, again, the main problem in this lady was that distal left main Medina 1-1.
Then let me challenge Cristoph here once more. So the first step of the job is done. Now I would say the major step is coming. You have this angiogram. Do you need any additional information to make your decision? What would be your strategy here to go on? Which technique you would prefer? What do you think? What is the best choice here?
Well, I think the good answer is always it depends, and it depends on the case. I mean, in this case, we have from the angiogram a lot of information. And I think it's very important that you choose your working views and the views to appreciate all the disease of the patient's coronaries completely. And so you really have to select. It's not possible that you work on one view only, and when you have a lot of vessel overlap, you should be very careful. Now the next would be to appreciate the entire anatomy, and in this case we have a distal left main lesion, so you need to think, would you like to go one stent strategy, would you like to go 2 stent strategy, and this you need to decide from the anatomy. If I look at this case, I would say this is clear Medina 1-1-1, as you already said. I totally agree. It looks there might be a little bit less disease on the corneosteum. So you can think of having a technique where you just stent from the left main to the LAD and then take a look how the ostium of the circumflex looks. So do provisional, think how it will look like. I believe there's enough disease there that you could also plan for an upfront 2 stent strategy, and then you have to decide. You do the main branch or side branch first, and the question is, what is main branch, side branch? Because in such a patient, I think it's always the LAD unless the circumflex is dominant. So you could choose a technique where you go for the main branch first. In particular, maybe also because the lesion on the LAD looks very, very tight, and I would be afraid if I go with the 6 French technique, which means that I cannot place 2 stents, then I would rather go maybe for the LAD first and then for the circumflex. If you use 7 French, it could be a different game.
Marco, what was your strategy?
My reasoning was that, with this circumflex, I was sure that that vessel will not survive without the stent because it's too diseased. So that's first thing. Another thing, during the procedure, I didn't want to, close that circumflex at any point. I wanted to secure it, to keep patency of all left coronary artery all the time. So therefore, I choose 2-stent strategy, and I went side branch stenting first, and then complete with the main branch left main stenting.
Just one question. You said side branch first, so there are different techniques. Which one will we see now?
Basically, it's a very good question because, my strategy was first, get pre-dilatation, get better flow, get better idea what's going on in the distal left main. And then basically, when I position the stents, then I think it's the time when you decide whether you can survive with T technique or you have to do mini crush in order to really cover the ostium of the circumflex.
Okay, so we will see. Good.
So, femoral approach, 7 French in this case, and I put workhorse wire to the circumflex. That was not a problem, but I had quite a lot of problems with wiring the LAD, which comes back to the point which you mentioned that that lesion was really tight. So I had to use hydrophilic wire for the LAD. Then, as I mentioned already, the plan was really to open the arteries. So I did first pre-dilatation of the LAD, and then followed by the pre-dilatation of the circumflex. And really, I was happy to see the full expansion of the balloon, even though I recognize that this is a rather small balloon to judge the resistance of the lesion.
Do you consider pre-dilation in case of left main as mandatory or optional?
I think it's optional. It depends upon classification, upon the anatomy. I think you just have to tailor your strategy to what you see on the angiogram. What about you, Cristoph?
I say in left main, I rather tend to pre-dilate because I really want what you said. I want to get a feel for the lesion. I want to have an understanding how the balloon behaves. And so I would rather, for me, it's mandatory, but I cannot speak for others.
We have a question from the audience, interesting question. You mentioned here pre-dilation, LAD, pre-dilation circ, and you mentioned that you did it one after the other. The question is why not kissing immediately?
I never do kissing because I think you just risk the dissection of the left main with 2 balloons. And then, of course, this can make your life more difficult. What about you? I don't know.
Yeah.
Do you use it?
I do not see so much a sense in that. I agree. I mean, the proximal size you can only approximate. It's in a native vessel. So I would not do it. I would go sequentially as you do.
Be also very careful with anything which might cause major dissections, because there is anyhow a certain moment when you have to rewire one of the branches, and if you have to rewire through a dissected area, then the success is not necessarily 100%. So you pre-dilated one by one. Okay, what's next?
And then actually I went to stenting, and I carefully positioned the 2 stents in a T fashion. So 3.0 by 12 from the left main, actually in the ostium of the circumflex, and 3.5 by 20 going from LAD to the ostium of the left main. So I wanted to cover the whole left main, even though the proximal part did not appear to be diseased.
Marco, can I ask you something? Because I think this picture shows very nice how you position your stents. So we see you have some protrusion from the circumflex into the left main LAD complex. What is now the difference, if we speak T-stenting or we speak mini crush or even DK crush, what is then finally the difference then?
I think it's just a matter how much you protrude the stent to the left main. And this depends upon the angle of the circumflex. If you can survive with T-stenting, so minimal protrusion, but yet you cover the whole circumflex ostium, then of course this will be a T-stenting. If you have to pull it back more in order to fully cover the ostium, the circumflex, this of course will become mini crush.
Okay, so the steps will be similar, but it's just a matter of how much you protrude.
And you know, I think it's very difficult to judge upfront the real information you really get at the point when you really position the stents, because you know the stents will change a little bit the anatomy, and then you will see where you are.
Right.
I think this very careful positioning emphasizes also that you really need to find the best projection to have a clear view on the opening of the bifurcation. Otherwise, you have no control over what you are really doing. So you placed first the side branch stent while having the main branch stent in position.
Yeah, remember I had 7 French systems, so I can fit 2 stents within the guiding catheter. And then you can see here I deployed the circumflex stent, and then the next thing was to deploy LAD left main stent all the way to the ostium. And in this particular situation, if you really wanted to cover, not to miss the ostium, so to say, it's very useful in this place to change the projection to the aleocranial or epicranial, where you can really appreciate whether you covered the ostium or not.
You know, one trick, in some cases you cannot really see you don't find the projection where you really see the ostium. But one trick I learned that you might take a third wire, just a radiopaque thing, floating in the aorta, just leaving the guiding. It will give an excellent marker where the ostium is, and you just position your stent up to there.
Yeah, that is helpful, indeed.
Yeah.
So, side branch is stented, main branch is stented. What next?
And the next step was, which I think is a very important step, proximal optimization. Because remember, the LAD stent is 3.5, and the left main, if you just sum the proximal LAD and the proximal circumflex and multiply by 0.67, you will see that the left main is at least 4.5 or so. So basically, the stent, the 3.5 stent in the left main will be not opposed.
So actually, your measure of the left main is based on this calculation, the Finet-Low distal main branch, side branch, multiplied by 2/3. So this is how you calculate the size of the left main. My question is, here we are facing with a 3.5 LAD. With a 3.5 stent, normally how far we can go in the left main? What kind of mismatch what we can still cope with, using with our regular stent?
This is a very good question, Gabor. There are several points. I mean, one thing is, if we look at the tapering, it is usually relatively big from left main to the LAD or to the circumflex. We have to keep this in mind. And like in other bifurcations, if I can say it like that, we would like to choose the stent according to the distal vessel, which would in this case be the proximal LAD. Because if you put the 4.5 stent in the LAD, well, this can cause severe dissection. So we want to open it up afterwards. And now how far can we go? In old times, this was also limited because the stents had, let's say, more restricted size. If we look at the stents, the modern stents, they can go up very high. Usually companies have 2 to 3 different sizes. So if you take, for example, a 3.5, it can usually go 4.55 plus. So it can go usually beyond 5, and you have no problem taking it up in the left main to these sizes.
We have in the meanwhile questions from the audience. What do you think about using IVUS prior deployment of stents? Is it necessary, useful, mandatory?
Well, this depends, again, it depends on the case. I know that there's a strong movement to use intracoronary imaging and strong recommendations also to use imaging in left main. We have to say, my first point would be to ask, what is the question that I have? Do I have doubts about the sizing? Do I have doubts about calcification? Do I have a difficult anatomy where I need to understand something? What is my precise question? So this would then answer the question if I would like to use additional imaging. And if we look at the data, we have to say it's interesting and good data, but these data are mostly retrospective and not really prospectively comparative. So we have to say there's a lot of hints that imaging can be useful, but to make it mandatory, I say I would rather tailor it to the patient. I think this is would be my personal approach.
Another practical question: should not the operator, so Marko, you, remove the wire from the circ before placing the stent in the LED? Let's phrase it in a way: what is the risk if you leave your wire in place, and what is the risk if you remove your wire prior stenting?
I mean, to leave the wire behind, you can risk that you cannot get it out or you can break it. I mean, that's theoretical risk, which, fortunately never happened to me so far. Maybe if the vessel would be very calcified and if you go high pressure, then probably this would be a danger. In particular, if you have the black part of the wire trapped. I think that's very important, that you don't get the black part of the wire trapped. Of course, this is an option and it's completely acceptable, and because the stent in the circumflex already secures the patency of the ostium. I learned to do it this way in the past, and since I didn't have problems, I'm not changing the things.
I see it in a way that since we are just discussing POT, when you place your main branch stent, so the left main LED stent, it will be massively malapposed in the left main anyhow, so removing of the wire should not be difficult. I see the risk of leaving the wire in place or leaving the wire in place for too long is more that it's behind your main branch stent, so your guiding will continuously hit your left main LED stent and maybe longitudinally compress it. So this is my reasoning mainly to, when I know that the side branch is done and secured, then I like to remove it first, because then I can engage my guide really in the lumen of the left main stent and not somewhere against it.
Actually, Gabor, this is a very good point, because very often when you have the wire, like you just told, under the left main stent, you cannot really re-engage the guiding, and so your imaging quality will get poor. This is also maybe something important. I think very good point, yes.
Yeah, in this particular case, I mean, I didn't have problems with the re-engagement of the guide because it's a big left main. But I fully agree with you. I mean, this is really a danger, in particular, for example, with this SAM French guiding catheter, that you induce longitudinal distortion of the left main stent by pushing the wire. So always, when I take the trapped wire out, or if I have a situation like that, I do it with the right hand, and with the left hand, I'm watching the guide and control the guide and pulling back the guide.
Not dives in, yeah.
Yeah, because that really prevents, this longitudinal compression of the stent.
Okay, so just back to the last step, you say proximal optimization with 4.5, which most probably fits also by calculation to the Finney law. So positioning of the pod balloon, I think it's a very delicate question, and this is the kind of key step of bifurcation PCI, how to position the pod balloon.
Yeah. I mean, the important thing is that you want to be just with your balloon at the carina. You don't want to cross the carina. This is at this point important, but it becomes in particular important when you have your final result, because in some intervention types you also create a carina, and you can completely destroy the carina if you put the big balloon over it. So you need to be just at the carina, and this can be different depending on what type of balloon, where the marker is. So this you need to know for your devices.
Okay.
And also, it's very important, for example, if you look at this scheme, if you go too far, let's say in this case with 4.5 below, you would move the carina toward the circ,
exactly.
And it would be very difficult then to get into the circ. In particular, remember, we have another stent there.
Yeah, actually, if you perform POT properly, then you improve side branch access. If you don't go too far, then you worsen side branch access.
Yes. So I would really, recommend people that, when positioning balloon for the POT, really take time, don't rush. Be sure, get the right projection, the right view, take your time, and then, do it.
Okay, POT is done, side branch, main branch stented. What's next?
So the next was rewiring. So after the pot, it was quite easy to get with another wire to the circumflex. Then
I would like to interrupt you because we have questions regarding this step. There was one question earlier that that when rewiring the side branch, being unsure or it might be difficult to really take the lumen of the main branch stent. How can you be sure that you are in the lumen of the left main LED stent and not somewhere behind?
This is very important question, in particular if you don't do wire exchange. For example, in this case, if I did wire exchange, which means I will be taking the wire out of the LED, knowing that for sure I'm not under the struts, and going to the circumflex, I will be fine. But if I go in with a new wire, even after a pot, the stent might be undersized and malapposed. So it's very important. I always make a loop. So I go all the way to the LED. If I have any problems, if I get stuck somewhere in the left main, if the wire does not travel smoothly to the LED, I just try it again, because the worst thing which can happen is that you get beneath the threads in the left main and then pushing your luck and then do the kissing and all the rest of the intervention. So I think this wiring is really critical. It has to go smooth, and then from the distal you go proximal and enter.
And actually with this answer, we can also immediately answer another question, whether to wire first the side branch or do pot first and then wire the side branch. And I think exactly this is why you do pot. So if you do pot, then the chance to go behind the stent is minimal because it's well opposed. If you do pot, you can engage your guiding properly, so you will go in the lumen of the stent, and it also improves the side branch access. Rewiring before pot, you have all the risk of coming behind, taking the wrong cell, and so on. So I hope you also agree that rewiring side branch after pot.
Yeah, because you want to take advantage of that pot. You're doing that because you want to have smooth rewiring.
Okay. What size of balloon do you choose for the kissing?
So as you see, I choose 3.0 for the circumflex to left main and 3.5 from the LED to left main. So these are exactly the sizes of the stents which I use. If I do 2 stents, I always use the same size of the balloon for post-dilatation and kissing as the stents are.
Yeah, but you have to keep in mind, it's similar like with Finnish law, what you just mentioned before. If you take 2 balloons, they will never just add up in size. Yeah. So it's not 6.5 at the end. These balloons, you usually take the diameters. So it's 3.0 plus 3.5 is 6.5. And then you divide by 2/3 approximately. So you will end up with something above 4, let's say 4.2 or so. So the proximal diameter will be around 4.2. And this is absolutely okay. This is what at least you want to achieve in the left main.
And maybe, I didn't emphasize enough this sequential kissing dilatation. So I place the balloon in the right position, and then I first do high pressure circumflex dilatation, deflate the balloon, do high pressure LED left main dilatation, deflate the balloon, and then I do kissing. And it's very important, and kissing I usually go maybe 6 atmosphere, not more than 8 atmosphere. And it's very important to deflate both balloons simultaneously, because you wanted to keep carina really in the middle.
And if you deflate sequentially, you would deflate the side branch first?
You mean after?
If you do kissing?
No, I
you do simultaneously?
Yes.
Okay.
Yeah, I know that there are different ways to do it, but again, somehow I got used to that.
No, it's agreed. I think both simultaneously is okay, and I think if you do sequentially, the reasoning should be that you do at least then the main branch as the last one, because there you want to have the stent opposed.
Okay, then whether is the final pot. We were also discussing a bit about that, whether it's mandatory, necessary, sometimes, always, never. How do you say it? Did you do final pot here? Would you do final pot here, Chris?
In this case, I did a final pot. The reasoning behind, as you can see it here, I did the pot, and I also did some flaring of the ostium of the left main stent. Maybe if I had to go there again, it's easier to get there if you flare it. I think the rationale behind is that, you know, I had 8 French catheter and there are some manipulations and maybe, you know, you damage a little bit the stent, maybe something like that. And here you have opportunity really to correct everything and get out.
Yeah, the most important thing in doing the final part, if you want to do it, if you decide, you have to do it correctly. Because you can, if you push it too deep, you destroy everything you did before. So be careful if you do it. If you want to do it, if you feel it's better, the stent is round, that is good. It's a good idea, but do it correctly. It's very important.
Okay, so at the end, we managed to review this case really stepwise together. First of all, just how to do really stepwise assessing clinical scenario, decide about the patient with surgeons, and how to do a T-stenting in clear 6 steps. Preparation of the lesion, careful positioning of the stent, first side branch, then main branch, proximal optimization, kissing with properly sized balloon, and again, final proximal optimization with properly sized balloons. So before we move on for the second case, there are some questions from the audience which we can quickly address. First of all, is it necessary to use a balloon pump for this case? What was the clear-lip class of this patient?
I don't think it was necessary, but you know, as I mentioned, I saw that tight lesions, and I think I felt much more comfortable to do it with the balloon pump, even though, of course, I recognize if this was a bad LV function and if the patient hemodynamically crashed, the balloon pump would not bail you out because you have to have a rhythm. So it's more like a pressure device than the flow device. When you see that tight lesions, when you increase the diastolic pressure and thereby coronary perfusion pressure, when the autoregulation is already exhausted, you may at least maintain in theory, at least coronary blood flow.
So we can agree this patient did not have too much reserve, so you wanted to stay on the safe side. The very practical question, Chris, is it mandatory to use non-compliant balloons for the kissing? It's recommended or it doesn't matter?
I mean, I think it makes sense, and this is more and more used since the new non-compliant balloons. They are, you know, they're getting better and their crossability is getting better. So I think it makes a lot of sense. Can you do it with semi-compliant balloons? Yeah, for sure you can do, but you need just to know the properties of the device. So they will react differently, and in case you really have to put higher pressures, which you normally do not have to do, then they would be really less favorable. Okay, thank you. I think you had a very nice result here, but so there is another case waiting for you.
So this is LAO caudal result, final result, and yeah, we don't have the aerial movie, but
so there is another case waiting for you, Marko. Okay. What kind of patient you have for us?
So case number 2. So this is again 82 years old, but this time man, gentleman. This is not an acute coronary syndrome. This is a stable disease, angina, exertional angina. And another major difference is that this patient had moderate dementia and preserved left ventricular ejection fraction. So already by the time, you know, we brought this patient to the cath lab, it was obvious that, you know, his mental state, so to say, was not appropriate for the surgery, for extracorporeal circulation, open heart surgery, etc. So it was either medical or, you know, we do something percutaneously. So this was a different dilemma as in the first case to start with. So coronary anatomy. So I'm showing right coronary artery LAO projection. You can see it's rather small, non-dominant, mainly supplying RV. So of course then if you see something like that, you expect a big circumflex. And really, this was the case. I have to say, Gabor and Cristoph, that in this particular patient, it was quite difficult, to get a nice view of the left main, quite opposite to the first patient where we really, angiographically see very nicely what was going on. So here you can appreciate areocranial on the left and the caudal on the right. Still, I was not really sure. I knew it was bad, but I didn't understand anatomy well based on these angiograms. And it turned out that basically the best view was really on the caudal side.
Yeah.
So I'm showing areocaudal, apicaudal was also quite good. But this is actually, what we got from the angiograms for this patient.
Sometimes what I do, if I cannot really find a good view, and then I have two wires in the vessels, and then I start turning under fluoro, and then you can see, how do the wires behave? Do they separate or do they come more above each other? And this sometimes helps you to see if you are going in the right direction, if you start to understand where does the bifurcation fully open. So sometimes it's helpful, but this appears to be the best view you can get.
So Cristoph, let us challenge you again. We can say this is again a left main case, but is it in any manners different from the previous?
Yeah, very, I would say. It's a very different case. I mean, it's number one, it's a shorter left main. So then we have to say that the circumflex is dominant. So, well, maybe side branch, yes, but maybe even less side branch than before. And then the dissemination of disease is different. I mean, you obviously see this proximal LAD stenosis, and you see at the origin of LAD a lot of calcium, which we didn't see in the previous case. And then what is also interesting, in the ostium of the circumflex, you have moderate but diffuse disease. And now look at the left main. What is always one of the criteria that I use is I look at the left main. And if the left main is not bigger than the circumflex, then I usually believe it's diffusely diseased. So I would say it's diffuse disease, left main to circumflex, and the tight stenosis in the LAD with calcium.
It's a kind of reverse thinking of the Fine law, just to give an idea about the stenosis of the left main.
Right.
So
and it was
nice
really,
approach.
despite this backflow, it was dumping of the pressure.
Yeah, this I can imagine. Right.
Yeah, so which is another old, I would say, cat lab criteria for the significant left main disease. So I fully agree with that analysis of the angiogram.
So then now, after this descriptive explanation, I also need an answer on the strategy what you would go for.
Yeah, I mean, we have again the same questions. After analyzing the anatomy, we know the most severe stenosis is in the LAD. Well, the circumflex is big, but I'm not so much afraid of losing the circumflex in this case. I could do two different things. I could plan for an upfront strategy, saying we have the diffuse disease in the circumflex, upfront 2 stents. Still, I would go first in the so-called main branch from left main to LAD, and then go to the circumflex, which would be a tap technique, for example, or which would be a kind of reverse T, or however you want to call it. The second possibility would be that you say we do provisional first, and then let's look at the ostium of the circumflex. How is it? And maybe we can keep it with 1 stent. So.
Okay, just to summarize then,
first left main LAD.
Main branch, left main LAD first, without most probably not too high risk of losing the circ, and hoping that maybe you can solve it with 1 stent.
Agreed.
Marco?
That's exactly, what I was thinking. I thought, okay, I have to fix left main circ. We have left main diffuse disease, left main LAD. We have diffuse disease left main and the tight LAD. And I also, I consider the fact which you mentioned that, the circ is the dominant. I knew that, after placing the left main LAD stent, the circ will look worse. I expected not to be closed. but I expected that I will have to stent it. If this was a small, non-dominant circ, I would probably leave it if there's a TME3 flow. But for this one, I thought, I have to do something more. So I said, okay, it will not close. I protect with the wire. I do the main stuff, and then I use the least complex technique for 2 stents in the distal left main. So this was my reasoning behind.
Yeah. I agree.
So let's see what we did. So again, even though you can do tap stenting with 6 French easily, I had the luxury. I could go 7 French. I feel more comfortable. I think when it comes to some problems, it gives you more freedom to do things. So, and if you are doing electively, I think it's probably a good choice. At least this is my strategy. So it was not a problem to put 2 workhorse guide wires to the LAD and the circ. And then just following what you mentioned in previous case, in this case really I wanted to see that non-compliant balloon completely expanded in the left main. And that actually was the case. You can see in LAO-cranial projection, the balloon going from the LAD to the left main, 3.0 non-compliant. And then, no, this is actually a stent, sorry. And then I did a stenting from LAD to left main. And here, of course, it's important really, to protrude and cover the whole left main, including the ostium. And again, I'm coming back to that cranial projection, which gives you opportunity not to miss the ostium, which might be also very difficult, in particular if the left main is so short as in this case, So 3.5 by 20 drug-eluting stents, and then I use 4.5 non-compliant balloon from ostium up to carina for pot, and here you can appreciate the pot, and you can also appreciate that I went from LAO cranial projection to the LAO caudal with best separation of the wires to really do pot in this projection, because I don't want it to push carina to the circ and make my life more difficult.
Can I ask, is there a trick, to know if your pot is sufficient? Because you choose 4.5, okay. Is there a trick how you could look at that?
For example, if you don't have an IVUS, and we discussed that before, you can, when the balloon is inflated, you can inject the contrast through the guiding catheter. And for example, if you will have a rough idea, if the contrast is flowing to the distal vessel, then probably the balloon is too small. If no contrast is appearing distally, then probably you have a good fit of the left main side. So this is, if you want a poor man IVUS
so
concept.
Analogy to TAVI somehow a little bit where we do.
Yeah, analogy,
Okay.
yeah.
Yeah, I would say it's not even if you don't have IVUS. This is something what doesn't cost anything. You are filming it or recording anyhow. To give a puff of contrast, it gives you a good reassurance that your pot is properly sized.
And nevertheless, there will be cases where you're not sure about the sizing and all this, and then you have a question, then you should maybe go to intracorneal imaging, definitely.
And another idea which I got through the years, for example, you do pot like that, and then if, let's say you go for provisional stenting, and then you're fine, everything looks good, and then you take the wire, the trapped wire out of the circ, and if it's going very smoothly, then you're probably still undersized.
So your
in
pot
the
was
left
not good
main.
enough.
Yeah.
Yes.
Okay, so main brain stented, proximal optimized.
Yes. And then basically, as I said, I decided upfront that I have to secure that dominant circ nicely patent. So I rewired. This was not a problem with a normal wire. And then I placed 3.0 drug-eluting stent.
Just a question. Did it go directly after rewiring to cross with the stent to the circ? Do you go directly immediately with the stent, or you open it, or you do kissing first?
Basically, in this particular situation, I don't do kissing because I decided for two stents. If, for example, if this was a non-dominant circ, I would just do the kissing and end up with provisional. But in this particular case, I already decided for a second stent, so I used 2.0 balloon just to make my way
to make the way open
to the circ, because I don't want to push the stent through the struts and then maybe get stuck there and lose the stent. That would be very bad and unnecessary complication, so to say. So I wasted another 2.0 balloon, get there, position the stent, as you can appreciate here, with the protrusion to the left main. Again, protrusion, minimal protrusion, which covers the ostium of the circumflex. So if your angle is like that, you will be pretty much doing T-stenting, provisional T-stenting. If the angle is getting like that, then of course the protrusion of the stent will be bigger if you really want to cover the ostium, and the neocarina will be longer.
So Chris, I believe that the positioning of the side branch stent is again the, let's say, the cornerstone of the whole T and protrusion technique. How you can be sure that you are positioned appropriately, or what are your steps or considerations during positioning?
Yeah, once you succeed to cross, and maybe this is something we can also discuss, what you do if you cannot cross. But let's say if you can cross and this works well, then you need to look, as you said, at the angle. This is something you need to know the markers of your balloon, because you need to know the distance from the marker to the balloon in your device, in your device you're using. At the end, with a stent, you want to cover the ostium, as you rightly said. And you want to have a very small neocarina. This is also important. So knowing the angle and knowing all this, you would like to have a full coverage of the ostium, and you would like to have as small as possible neocarina. This is the criteria you need to look for.
Okay. Kissing, mandatory after side branch stenting?
So yeah, let me say, before deploying the circumflex stent, I placed the 3.5 balloon, from the left main to the LAD. Again, this is the same size balloon as the stent. And then under protection, or whatever you call it, I deployed that stent. And then it's very important to withdraw the empty balloon from the circumflex a little bit, and then do your kissing.
So actually you use your side branch stent balloon plus another balloon in the size of the main branch. Exactly. For the kissing.
For the kissing, exactly. Yeah.
Pressures?
Usually I do my kissings, between 6 and 8.
Okay. So, are we done with the procedures? Kissing is done, stents positioned. Do we have to do final pot or not? Again, this is something we were discussing about, that what are the pros, what are the cons of doing final pot after tap technique?
I mean, it was already a little bit mentioned. You can destroy with a final pot also your neocarina. And this becomes very important with the tap technique, because in tap technique you are very meticulous about your small neocarina to make it well. And if you place the balloon too distally, you will push it over. So in tap, I really tend to avoid it, and I rather don't use it. Would you use it? Yeah.
I didn't use it,
okay.
And I'm not using it in tap like Cristoph, because I think you really, you don't know exactly where your neocarina ends. And if you don't know that, you will not know how to exactly place the tip of the pot balloon, if you want. And then if you go too far, then you pretty much destroyed everything you did. You perform a crush. You will have to probably rewire, rekiss, and all the stuff. So considering the fact that, at least, in terms of clinical endpoints, there's no real data showing the benefits of the, let's say, final pot, I think for this particular technique, it's wise to skip it.
Maybe Gabor, one question. So because we were briefly addressing it, this if you cannot recross, I think there's one important message we have. Many people are very fast looking, if they cannot recross with a stent, at applying more power, more support, stronger wire, some catheter and catheter, mother and child catheter to push. I think this is something we need to emphasize. This is often not the problem, not to have enough force. Sometimes it is just mechanical resistance. You need to alter the angles how you attack. So understanding why you cannot recross would be my most important message, because as you did it here with recrossing with the stent, it's sometimes difficult and you need to really understand, not just put more power.
Yeah, but I think it's a very good point that normally it's not the force what solves the problem, but a bit of thinking and changing something in the setting, wire position, distal wire position, crisscross of the wires or so. Yeah, but power is, or force is rarely the solution in these cases. Before we close this case, there are a couple of questions from the audience what we can address. First of all, does rotablator could be important for this calcified left main LED ostium? Well, you achieved a nice result now with balloon alone.
For this particular case, after you see a nice expansion of the non-compliant balloon, I think, this is a proof that for this particular case, you will not need a rotablator. Of course, when for example, you have a tight lesion, calcified, and then you do 2.5 pre-dilatation and you see that waste which wouldn't go away. I mean, then of course this is a rotablator or cutting balloon case. Of course you have to prepare the lesion, in particular if this is the left main.
Question to Cristoph: what do you think about self-expanding and dedicated stent for left main bifurcation? Do they have the role now or in the future?
Well, the self-expanding device is sometimes very useful. If you have a very strong tapering, it can be really useful because you might not be able to achieve a good result without. So I think, yes, this is a good idea. With the dedicated stents, I have a little problem. We tried many of them. None of them showed an advantage. And at the end, they mimic somehow the anatomy. But I think we are better at mimicking the anatomy because we don't have a prefabricated stent. We try to tailor our stents then to the individual anatomy. And I think this is better.
Okay, I think we managed to address most of the questions. So just to summarize once more what we learned from this last case, that again, a very careful stepwise approach to this complex anatomy resulted in a very nice result, meaning proper lesion preparation, being sure that your balloon expands, then your stent will expand, stenting main branch first, because this is what you want to secure, and then, let's say, protecting the side branch with an additional stent, where the key point is most probably the positioning of the side branch stent, not to be too deep or not to be too much outside in the side branch. So we stented now 2 patients in the left main. Chris, would you have any special consideration during the discharge of these patients regarding, for instance, follow-up or double antiplatelet regime?
Let's say this is a normal smooth case, like we just saw 2 very nice cases from Marko. I just follow these patients up like I would usually do, no follow-up unless clinically indicated. Dual antiplatelet therapy depends also on the patient. If I have a patient like this, I would follow the normal 6 months regimen. If the patient has a high bleeding risk, I would be a little bit more reluctant than in other cases to reduce to 3 months or even 1 month. Should be very special selected cases. Would I go in routine longer? Well, only if I believe that this patient is at high risk because a lot of calcium, no good apposition to achieve, or any other additional risk factor.
Marko, we also see in the questions here, and I'm sure that many people expected that we will talk about the DK crush and culotte, which are now, data are coming. Still, you did both cases with the TAP and the T-stenting. What is the reasoning behind?
Basically, I'm using the technique which I'm used to and I'm familiar to. Of course, I'm familiar with the randomized trial on DK crush. It's an excellent trial. The only issue is that the control group, the provisional group, it's really not what I do in my real life, and I think it adds additional complexity and additional metal in the left main, and I wanted to reduce the amount of metal in the left main to a minimum.
So you say that the simpler and the less metal, the better, and the more familiar you are,
That's my approach. That's my approach.
Chris, what would be your message to all our audience, what we should take home from this 1-hour session?
I think planning ahead is important in this patient. You need to have a stepwise approach which you follow. You need to, at all the time, to know what is my next step. And then you should be prepared if it doesn't go to your liking. So what could be the reasons and what can I do?
I think it's a very nice closure message to all of us and to everyone who followed this webinar now. So I would like to thank your participation. I would like to also thank the participation of the audience. Thank the PCR team and Medtronic to supporting us. And don't forget, this was the 3rd module of this series of webinars. And in the end of October, you will have the next one about treating calcified left main stenosis. Thank you very much for your attention. Thank you very much for being here with us. Thank you.